Most people over 65 have been told their blood pressure is too high and that they need to bring it down, and they take their medication every day, dutifully, assuming that lower is always safer. But there is a clinical phenomenon that most patients never hear about, and that their doctors often do not have time to explain, that changes this picture significantly. It is called the J-curve, and it means that for adults over 65, blood pressure that is pushed too low carries its own serious risks that are just as real as the risks of blood pressure that is too high. Today, I want to give you the complete clinical picture, what the J-curve actually is and what the data shows, when blood pressure medication may be doing more harm than good, how to monitor your blood pressure at home in a way that gives your doctor accurate information, and the specific questions that could open the most important conversation you have had with your physician in years. My name is Dr. Elizabeth Kavaler. I am a board-certified urologist and urogynecologist with over 20 years of clinical practice. Blood pressure management is directly relevant to my specialty because the kidneys and urinary system are among the first organs affected by both hypertension and its aggressive treatment. What I am sharing today is based on published research from JAMA Internal Medicine, the American Geriatric Society, and the European Heart Journal, and it reflects the current thinking in geriatric medicine that is transforming how we approach blood pressure in older adults. The J-curve is one of the most important and least discussed concepts in cardiovascular medicine for older adults. Here's what it means. If you plot blood pressure on a graph against mortality risk, you might expect a straight line. Lower blood pressure, lower risk, in a simple linear relationship. But what the data actually shows for adults over 65 is a J-shaped curve. Risk is highest at very high blood pressure. It decreases as blood pressure comes down into a healthy range. But then, and this is what most patients are never told, risk begins to rise again as blood pressure drops below a certain threshold. The curve turns back upward, hence the J-shape. A large study published in JAMA Internal Medicine, examining over 4,500 older adults, found that the lowest mortality risk sat at a systolic blood pressure around 130 to 140 millimeters of mercury in adults over 75. Below approximately 120, mortality risk began to increase. This is the J-curve in clinical practice. The mechanism is straightforward. As I have explained in a previous video, aging arteries are stiffer. The brain, kidneys, and heart require adequate perfusion pressure to receive enough blood flow. When blood pressure is pushed below the threshold, those stiff arteries need to maintain organ perfusion. Blood flow to critical tissues decreases. In the brain, this can cause cognitive decline, dizziness, and falls. In the kidneys, it accelerates function loss. In the heart, it reduces coronary perfusion, the blood flow the heart muscle itself needs to function. The J-curve is why the American Geriatric Society recommends a target range of 130 to 150 systolic for older adults over 75 with multiple medical conditions, not below 120. That range captures the protective benefit of treating hypertension while staying above the threshold where too low pressure creates its own harm. There's a shift happening in geriatric medicine that I believe every patient over 65 should know about. It is the shift from treating to numbers to treating to the person. Treating to numbers means your blood pressure is 145. The guideline says it should be below 130, so we increase your medication until the number falls. The target is the number. Treating to the person means asking a different set of questions first. How does this patient feel at 145? Are they dizzy when they stand? Do they have falls? What is their cognitive function? Do they have kidney disease that affects how they tolerate low blood pressure? What is their life expectancy? And what is their personal priority? A lower number on a machine? Or the ability to walk to the kitchen without lightheadedness? Research published in the European Heart Journal found that frail older adults treated to aggressive blood pressure targets had worse functional outcomes than those managed with personalized, less aggressive targets, even when the aggressive group achieved lower numbers on the cuff. The number went down, the patient got worse. This is not a reason to abandon blood pressure treatment. Untreated hypertension at 160 or above remains dangerous at any age. The point is that the right target for you is individual. And as a patient, you have the right to have that conversation with your doctor. Deprescribing is the clinical term for the deliberate, supervised reduction or discontinuation of medications that may be causing more harm than benefit. It is an established and growing field in geriatric medicine, and it applies to blood pressure medication more than almost any other drug class in older adults. Research published in JAMA Internal Medicine found that many older adults on multiple antihypertensive medications could safely reduce their medication burden under physician supervision, with blood pressure remaining within acceptable ranges and significant improvements in dizziness, fatigue, and cognitive clarity. The conditions under which deprescribing is most appropriate include blood pressure that has been consistently below 120 systolic for 6 months or more, symptoms of low blood pressure such as dizziness on standing, falls or near falls, unexplained fatigue, or cognitive fog. Also relevant is taking 3 or more blood pressure medications simultaneously, having been on the same regimen for many years without reevaluation, and significant changes in body weight or kidney function since the medications were last adjusted. If any of these apply to you, this is not a reason to stop your medication on your own. It is a reason to initiate a specific conversation with your prescribing physician. The question to ask is this: given my current blood pressure readings, my symptoms, and my overall health picture, is there an opportunity to review whether my current medication dose and regimen are still the right fit for where I am today? That question is not challenging your doctor, it is participating in your care. And it is one of the most clinically important questions an older adult can ask. Home blood pressure monitoring gives your doctor far more useful information than a single clinic reading, but only if it is done correctly. Here are the 5 most common errors that make home readings inaccurate. Error 1. Measuring immediately after activity, eating, or coffee. Blood pressure fluctuates significantly for 30 minutes after any of these. Always rest quietly for at least 5 minutes before taking a reading. Error 2. Crossing your legs or having your back unsupported. Both raise blood pressure artificially. Sit in a chair with your back fully supported and feet flat on the floor. Error 3. Using the wrong arm position. Your arm should rest at heart level, supported on a surface. Holding your arm up or letting it hang down changes the reading by 5 to 10 points. Error 4. Taking only one reading. Blood pressure varies from minute to minute. Take 2 readings 1 minute apart and use the average. If the 2 readings differ by more than 10 points, take a third. Error 5. Measuring at unpredictable times. Blood pressure follows a circadian pattern. It is typically highest in the morning within 2 hours of waking and lowest in late afternoon. Always measure at the same time each day, ideally morning and evening, for readings your doctor can actually compare over time. Bring a log of at least 7 days of readings to your next appointment. That log is more valuable than any single clinic measurement and will anchor the deprescribing conversation in real data rather than assumptions. You are not a number on a blood pressure cuff. You are a person with a unique physiology, a unique medication history, and a unique set of priorities for how you want to feel and function. The J-curve is real. The evidence for individualized targets is strong. The conversation about deprescribing is one your doctor is increasingly prepared to have, if you ask. Measure your blood pressure correctly, keep a log, bring it to your next appointment, and ask the question. I am Dr. Elizabeth Kavaler. I will see you in the next video.